Chapter 40. In this chapter we're going to cover spinal emergencies, spinal injuries. For the most part, a lot of it is repetitive from EMT. A few things that we hit on advanced-wise here. Number one, the possibility of neurogenic shock and the treatment of neurogenic shock now that you're an advanced provider. And secondly, there's a couple of different types of cord injuries or cord issues that we will touch on that are a little bit more advanced than, say, at the AEMT or at the EMT level. So some things like specific injuries to specific parts of the cord. So it is a little bit longer chapter as far as slides and as far as pages, but a significant portion of it has to do with the treatment of the various types of injuries. And much of that has not changed as when we discuss things such as supine, seated, or standing spinal immobilization, application of C-collars, and so on and so forth. Still on the same advanced EMT education standard where we're able to apply fundamental knowledge, provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely injured patient. Of course, we have several objectives in this chapter that we'll find on 881, 82, and 83 in your textbook. All right. So individuals between the ages of 16 and 35 sustain spinal injury more frequent than others. So high-risk activities. This kind of goes to back up a statement that I've used in the past, that is that your first 40 years, the stupid stuff you do kills you now, and it's the second 40 years of your life, the stupid stuff you did back then is what kills you then. So the immediate causes of frequent causes of death for this age group include things such as traumatic injuries from motor vehicle crashes, falls, penetrating injuries, sports injuries, so on and so forth. So because this is a much more active age group than, say, the pediatric population, which is still quite reserved and generally tends to be a little bit more clinging to their parents, there's a lot more watchful eye from the parent, as opposed to once they hit 16 and now they're able to take themselves out to do whatever that is that they think they need to do. And then leading up through, age 35 or even knocking on 40, where you're now starting to slow down a little bit in your life again. So spinal cord injuries can lead to permanent disability, sometimes leaving the patient paralyzed, whether paraplegia, quadriplegia, and sometimes it's so bad that they're really almost in essentially a vegetative state. So they also can be fatal. The higher up you go on the spinal cord, the greater chance you are of having it take out your respiratory drive. So when we have that potential for a spinal column injury, we need to restrict the motion of the spine, first manually, and then by securing the patient to a long spine board with a cervical collar in place when possible. We can't always get a C-collar in place. We can almost always get them on a backboard. May not be perfectly laying flat on their back, but we can usually get them onto a board. Now, this is the current standard of care, and will continue to probably be the standard of care for some time, at least as some of the current theories start to get worked out, that if they have strong suspicion, if they have positive signs pointing towards it, they're still going to get immobilized. However, what is changing is the blanket. Everybody gets immobilized if you're in an accident. That is changing. That's going to change because we know we're not doing people any good. There is even suggestion that even using a long spine board is not really truly doing people any good to immobilize them. That still remains to be seen, but in the future, and it's actually already being discussed in Iowa, assessment-based immobilization will become a much more frequent topic of discussion and will be used probably at all levels from the EMT up. The cervical spine is very delicate. It's much more prone to injury. There's no supporting extra tissues to help stabilize it. You know, with the thoracic spine, lumbar spine, even the sacral spine, those areas have tissue around them, whether it's pelvis or it's abdominal muscles or it's ribs or what have you. There's much more bulk around those areas, so they have more quote-unquote padding. When we have cervical spine injuries, we're possibly talking about this, 10-ish pound weight on the end of this whip that we call the cervical spine. So you got this heavy head on this delicate little spine, 7 vertebrae, that causes whiplash a lot of times. So that puts it much more at risk, much more prone. The risk factors for cervical spine include injuries to the head and face, because if it can whip the head or face around, the chances are good that it can cause damage to the spine. If we look at the girth, the structure, the density of the bone in the cervical vertebrae, outside of that of the tailbone or the coccyx, they're the most delicate. Okay, they don't have as much bony structure to them, so it's much easier for them to be pulled on and broken. GCS of less than 14 is also a predictor of cervical spine injury, provided that their GCS wasn't lower than 14 to begin with. But that GCS of 14 tells us, hey, there was enough of an insult here that it's caused alteration of mental status, and that patient with altered mental status is possibly not the most reliable person for us to get a history from to tell us whether or not their back hurts. That goes with your case study. All right, so the CNS and the PNS, this is all solely really showing the central nervous system per se in the pictures here. But the picture shows us the brain and it shows us the spinal cord, which is the central nervous system. And the peripheral nervous system are all the nerves that are not really shown here. So the 12 cranial nerves that come off the base of the brain, they're not shown in the picture, as well as all of those spinal nerves that come away from the spinal cord and then also bring information back to the spinal cord. All of those are considered the peripheral. All right, so the central nervous system and the peripheral nervous system communicate with each other. We have various tracks in which they do this on. So the tracks of gray matter, we hear about gray matter actually quite a bit. So the tracks of gray matter, which are nerve cell bodies, okay, and white matter, which are nerve fibers and axons. Okay, so the body, or the main structural component, is the gray matter, and the white matter is the extensions. Then these allow the nerve signals to be transmitted up and down the spinal cord between the brain and the peripheral nervous system. Remember, not everything makes its way to the brain. Occasionally we have things such as reflexes which do not. And I think we get to those here in just a little bit. So if the spinal cord is completely severed, communication from that point in the cord downward ceases. Remember, all of these wires kind of come together really at the spine. So we don't really truly have a collateral communication system, if you will, meaning we don't have extra circuits somewhere else that can send nervous system communication via the back route. So if you were to think about a network of wires, if we were to think of them as being like laid out in a grid, and maybe we have a grid system set up for the electricity or the phone systems or whatever in our municipalities that we live in. So certain points, if there's a wire cut or plumbing, I guess, is a great example. Whereas a lot of cities will have those networks of pipes where they can shut off a valve and only cut off, a few houses, maybe a block of people from water, as opposed to an entire portion of the city being shut down. We don't have that. It's all really kind of in one way, out one way. That is not the case, though, with hormones. Remember, hormones don't follow nerves. Hormones are involved with nerves. Hormones are those nerve synapses, but hormones don't follow the nerve tracks. Hormones are in the blood, typically transported within the blood. So that's why sometimes we still get some changes in the patient who is got this complete severing of the cord, where their body still kind of keeps up, per se, but there's no communication back and forth as far as the nervous system. And we know that this CNS is the brain and the spinal cord, and the PNS is the other tissues outside the central nervous system. We have efferent and afferent nerves. So efferent are motor nerves, and afferent are sensory nerves. So the afferent nerves are the sensory ones, and they help us be aware of our surroundings. That's kind of a way I remember that, is aware and afferent. Both start with A. They help us sense the things around us, so the pain, the heats, the colds, and as well as all of our special senses on top of that. So they're going to initiate signals that travel toward the brain and the spinal cord. It also has to do with knowing where we are in the space-time continuum, if you will. So knowing the position of your hand, knowing if your knee is bent, something along those lines. Whereas efferent is the effect. So we sense something through the afferent, and then the efferent is the effect that it's going to cause is we're going to cause us to move our hand or move our leg or walk across the room or whatever. So efferent is motor nerves, and these are signals that go from the brain or the spinal cord down to the end organ. So basically to the skeletal muscle cells. So that's what we're aiming at, is to move something. So the efferent portion is divided into the autonomic and the voluntary divisions. So the autonomic nervous system further divided into the sympathetic and the parasympathetic. So the voluntary division is those things that we generally do with some thought. So mostly it is our skeletal muscle in most cases. So the skeletal muscle is mostly voluntary, that we decide to pick up something, walk across the room, chew something, whatever. Whereas the autonomic, remember, autonomic is typically automatic. So sympathetic, fight or flight. Parasympathetic is rest and digest. So when we have a disruption in the ability of the signals to travel to and from the brain, those body functions are affected. So we talked way back when we talked shock and pathophys and whatnot. We know that part of the problem with neurogenic shock is that the blood vessels just decide, well, nobody's telling me to be small, nobody's telling me to be large, I'll do what I want, and what I want to do is relax. And so they relax, they open up, and then we have too large of a container for all of our blood. So that disruption is what causes us to have typically hypotension in the presence of a spinal injury. So the nerves do not have the ability to regenerate, and when that injury occurs, those results are generally permanent. Granted, there are always advances in medical science which are showing some promise, but yet we don't have the fix. We don't have the permanent fix yet. We don't have ways to put people back together completely and wholly. They've done some experiments with stem cells and whatnot, and trying to regenerate some of these nerves, but trying to reestablish some connections in these routes, but yet we're still so far from any permanent fix. So again, I was talking about the how delicate the vertebrae are, and this picture gives us a good example of really vertebrae from the three major groups of vertebrae. And the first two are actually from the same group, from the cervical vertebrae. Remember, it's 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and then 3, 4, or 5 coccygeal. But so the first two, we have the atlas, which is the first cervical vertebrae. The second cervical vertebrae is referred to as the axis. So the atlas allows us to nod our head yes. The axis allows us to shake our head no. So the atlas, the facets on it allow the kind of glide back and forth, up and down. And then the axis actually has something called the odontoid process that comes up through where you see the spinal foramen. Let me highlight that a little bit. Okay, spinal foramen right here. So the spinal foramen, this isn't it right here, but there's a point that comes up off of the body of the spinous of the vertebrae of the second cervical vertebrae, or the axis, and it sticks up through there. And because you notice this spinal foramen is much larger than the rest of these, and that's because that odontoid process, or the little peg that sticks up through there, that allows the twisting motion of actually the first on top of the second. So that first cervical vertebrae, or what we refer to as C1, fairly delicate, doesn't really have a spinous process on it. Has a little bit of a transverse process which comes off the side there to give it some side stability. But and then the others all have a fairly prominent spinous process. They'll have the fairly prominent transverse processes. Of course, they have the spinal body, or the vertebral body, which is the major bulk of it that allows it to sit one on top of another. Remember, that's where the discs will fit in between one vertebral body and the next one. In some places we may have a transverse foramen, and the transverse foramen, particularly in the cervical vertebrae, is routes for blood vessels to travel. We have the lamina, which is kind of the parts that bridge the gap between the various processes, and then we have the pedicels, or the pedicles, which bridge the gap from the body, the vertebral body, to the transverse processes. So you can see that those first two are fairly delicate in the grand scheme. As we look down at, say, the thoracic vertebrae, which is definitely fairly bulky, and then we look down there at the lumbar vertebrae, and whoa, I mean, we've had a significant change as we've progressed down. We don't look too much at the sacral or the coccygeal vertebrae, simply because they're generally fused and they don't have nearly as much articulation as we do with these top three groups. All right, so it extends from the base of the skull down to the pelvis. This is the spinal column, not the cord, spinal column. And it's typically 33 vertebrae stacked on one on top of each other or fused. And remember, the fused vertebrae are typically those down there of the sacrum and the coccyx. They are the non-fused vertebrae are separated from one another by a fibrous intervertebral disc. So when you hear about slip discs, or a person who has a herniated disc, that's what we're talking about here. And then each vertebrae has a hole through the center of it, which is the vertebral foramen, and that houses and protects the spinal cord. This is not necessarily true down through the sacral and coccygeal vertebrae. They're generally pretty solidly fused. The spinal cord itself actually progresses down only to about L2. So the second lumbar vertebrae is where the spinal cord generally stops. So the 5 regions: cervical, thoracic, lumbar, sacral, and coccyx. Cervical vertebrae, we have 7, and they're numbered C1 through C7, starting at the skull, heading downward. Thoracic, we have 12, and they're numbered T1 through T12. The lumbar vertebrae, we have 5 of those, and again from top to bottom are L1 through L5. Sacral vertebrae and the coccyx on the inferior region of the spine, 55% of spinal injuries occur in the cervical spine area. Again, we talked about they're not well protected. So we have a large number of muscles and ligaments that support, hold, and stabilize the spine. They do allow for movement. So as people develop more and more back pain over time, a lot of times it's from muscle atrophy, so they're not using their muscles quite as much. So they don't have as much support there. So when you have nice, finely tuned, strong muscles in there, holds everything nice and steady, it makes it much easier for everything to kind of work together. And like I mentioned, the cervical spine, most prevalent injuries, and it's because of that heavy head, causes hyperflexion or hyperextension or excessive rotation. So remember, hyperextension is leaning your head back as far back as it'll go. Hyperflexion is touching your chin to your chest. And of course, rotation would be turning side to side. So if you're looking, if you've turned your head 90 degrees and you're looking out the side window of your car and watching the car come and hit you, the different forces that are at play here, that could actually cause some excessive injury. So the spinal cord comes out of the brain, basically through the brainstem, continues through each vertebral foramen, down through the L2, and then it separates into nerves. It separates, the spinal cord has nerve roots coming off of it the entire way down. But once we get down to the bottom, down there to L2, instead of being one solid cord, beyond that it becomes something called the cauda equina. And that cauda equina is, if you know anything about horses, you know equine has to do with horses. It refers to the look that it has being a horse's tail. Well, it's like a whole bunch of wires, nerves that have been now separated. So we don't have a single solid cord anymore. We just have lots of little fibers and nerves. So those nerve roots, they extend from the spinal cord through these small tunnels or the neural foramina. And if we look at a spinal column from the side, I'll have you flip to page 887 in your textbook to kind of get this idea. But if we look, any one of those examples of the spinal column there, they don't show it, but where we're seeing the yellowish coloring intermixed between the different, between the muscle fibers, if you will, which is the reddish color, and then the gray of the vertebrae. So towards the right side of each one of those pictures, where we're seeing the gold kind of peek through there, that's where the nerve roots would come out. So they'll exit through those little tunnels there to come out and feed the various areas of the body. So they're going to carry these impulses from the body to the brain and vice versa. All of the muscle functions, voluntary and involuntary, result from nerve impulses. Okay. Now, we kind of have that one special muscle that kind of does his own thing, and that being the cardiac muscle. But even then, the vagus nerve, which is one of the cranial nerves, has influence. So the nervous impulses, they'll travel to the diaphragm via the phrenic nerve, which is another significant nerve, comes out very high in the cervical vertebrae. It exits high up on the cervical vertebrae and then travels down through the soft tissues to feed the diaphragm. So an injury in the spinal cord that's high cervical can injure or sever that phrenic nerve. and that will cause a failure of the diaphragm to contract, and obviously will cause you to have a life-threatening ventilatory insufficiency. Okay, we know that the phrenic nerve feeding the diaphragm is not the only drive for ventilation. We also have the intercostal muscles. However, chances are pretty good that those nerves will be affected as well when we're talking about the phrenic nerve getting damaged. So there may be some minor agonal or gasping style respiration going on if they still have some of the chest muscles intact and the chest muscles able to work. However, not having the diaphragm, our major driver, takes us out of the ballgame really pretty quickly. So the nerve roots of the spinal cord provide for reflex action to take place. So a reflex is when it does not actually make it to the brain. It makes it basically to the spinal cord and bounces back. So in this case, a reflex, we could think of it as our spinal cord being a trampoline. It sends a quick signal. The afferent system sends a quick signal that says, hey, this is bad. We need to fix this right now. We don't need to think about this. It's dangerous. Fix it now. And it bounces, boom, hits the spinal cord, boom, shoots back through the efferent tracts and says, okay, move it. If it's bad, move it. So that's how a reflex works. It's not processed by the brain. So we have ascending spinal tracts that are going to carry these impulses from the body to the brain. Ascending meaning going up. I guess you could associate it with afferent as well. But it gives us our senses. We have the descending, which you could associate with efferent. The descending spinal tracts carry those motor impulses from the brain to the body or from the core to the body based off of the incident. And they control our muscle activity and our muscle tone. So the ascending nerve tracts are divided into tracts that have various types of sensation. So might be things that are tactile sensitive, such as a soft or light touch, pressure, pain, temperature, vibration, things that we don't think about. We talk about our sense of touch, our sense of feel, but when we really think about it, it can be very complicated. I mean, because there's sensations of different textures. There is, the heat and the cold. There's the pain and the pressure. And when we talk about pain, look at how complex pain can be. Is it a somatic pain or is it a visceral pain? And maybe it's not a pain. Maybe it's a pressure, quote unquote, pressure-like pain as opposed to a sharp pain or a dull pain. So these things can be quite complex. Now, a lot of that obviously requires the brain to figure out, and it depends on the amount of sensation nerves, amount of tactile nerves that you have in a various body part. Obviously, some parts of your body are much more tactilely sensitive than others. If you have something that's become thickened from a callus, it's going to be less sensitive, where you might have something that's frequently protected and doesn't get touched very often. And in those cases, it might be ultra-sensitive. And a lot depends. A lot depends on how you've taken care of your skin. If it's intended to have been sensory organ, say something like the back of your neck. We wouldn't typically consider that to be much of a sensitive organ. So there's probably not a lot of receptors back there. So you may have done this experiment in an elementary science class where you took two stick pins, straight pins, and then varied how wide apart they were, and you maybe started with they were very, very close, and you thought, well, no, there's only one pin or only one point or tip there, and then you slowly got the two tips of the pins farther and farther apart until you could say, oh no, there's definitely two there, and that helped us to decide, okay, this area is more sensitive, this area is less sensitive, so on and so forth. So, not all injuries to the spinal column results in injury to the spinal cord. We are lucky in that case. Probably the most commonly broken parts of the spinal column are some of those processes that come off. So whether we're talking a transverse process or we're talking a spinous processes are the ones that come off straight backwards. So the spinous process, if you wanted to think of us, if you want to pretend that we evolved from dinosaurs, that would be the Stegosaurus plates that came directly up off the back there. So if we had big spiky processes coming directly out of our back, that would be our spinous process, where the transverse process gives sideways stabilization or lateral stabilization. So those are probably the more commonly broken parts of a vertebrae, although there is also the potential for there to be damage to the spinous, or for the vertebral body. So the vertebral body, that thick, heavy part, which is separated by discs that stack one on top of each other, those can also be broken and not protrude into that spinal canal. And if that's the case, these are people who end up with chronic back pains and whatnot, but yet probably didn't end up with either any nervous involvement or had only temporary nervous involvement. So we'll take, for example, a person who had a fall, fell directly onto their feet with locked knees, and then that vibration, that force was transmitted up through their body till it got to the small bones, because remember, if we're falling onto our feet, we're falling on calcaneus bone, which is fairly thick, fairly heavy. Tibs, fibs, femurs, pelvises, those are all fairly heavy bones, and then we get these fairly light bones of the vertebrae. So that's where some of these impact or compaction style injuries can occur to the spinal column. So immobilize the spine so that movement does not worsen any injury that does exist. So if we have this person who's maybe not starting to show any signs, but yet they're complaining of it, the reason we immobilize them is just because they don't have a problem now doesn't mean it's not going to develop. The thought process that kind of goes behind this is, well, maybe they crunched a vertebrae, but everything's kind of still sitting in the same spot. The more they move, the greater chance of a little piece, chunk, or tidbit of bone working loose out of where it was sitting and now starting to protrude or intrude upon the spinal column where the cord sits. So a little bit of pressure, there's not a lot of extra room in there, a little bit of pressure of this little bone fragment on the spinal cord can have a very drastic result. So what are the mechanisms of injury to the spine? And we can see all those. I had you flip to this page earlier, 887. Here are the major mechanisms that we talk about when we're discussing spinal injuries. So we may be talking something like a flexion injury. So this person has fallen down the stairs. They've hyperflexed. Remember I said hyperflex is chin to chest. So when they have done this, it's possible to dislocate one spine or vertebral body off of another. It's possible that it's a strong enough force that it actually starts to compress on the front side, the anterior surface of that vertebral body, and start to cause it to crumble or crush. And as this picture also shows us, can cause some injury to the muscles in that area. We may have a compression injury. And that compression injury where you kind of get a straight on either from the foot up or from the head down injury in which the body's weight is traveling in one way and now comes to a complete quick stop, and that energy is transferred up the bone, up the bone, up the bones until it reaches a vertebrae that's able to give a little bit. So it causes a crushing of the vertebral body. We have hyperextension injury. So now we've relaxed our head way back, and here we get less support from the vertebral bodies, and most of the support then is going to be transferred to the muscles and to the spinous processes, causing some of those spinous processes to crumble. We have a distraction injury, where the distraction injury is like a hanging, where we're actually pulling them apart. And when we pull them apart, we know just like with any other dislocation, you pull things apart, the chance of a loop of vessels, nerves, whatever, getting caught in between there when they come back together is pretty good. We could have a flexion rotation injury, so somebody who's fallen, did a head over heels and sideways, and upside down, and whatnot. That's kind of a crapshoot as to what could happen there. Tear some muscles, break some bones. Penetrating injury. Penetrating, something goes directly in there and either hits maybe one of the vertebrae itself, perhaps is lucky enough to slip through and hit the cord. So those are the various types of mechanism that we may run into. We have a few others. Lateral bending, which we don't have recognized in the pictures here. The lateral bending injury, and it causes them to slide to one side or the other, typically causing some damage to the transverse processes. And I think we got the rest of those. Compression, hyperflexion, hyperextension, rotation. Rotation is the twisting. So, right. So, spinal column injury versus spinal cord injury. A spinal column injury, damage to the musculoskeletal structures, such as the vertebrae or the ligaments and or muscles of the spine. So the column itself, the bony structure, and what holds that structure in place is injured in the column injury. Whereas the spinal cord injury, specifically the cord is damaged. So this is probably in conjunction with a column injury, because most cases the column had to fail in order for us to see something protrude into the spinal canal. So they usually, if you have a spinal cord injury, you probably have a spinal column injury, but that's not always vice versa. The primary injury result of compression or shearing of the cord, and is usually a direct result of the mechanism. All right, we may also have some secondary injuries to the spinal cord, so that occurs after the initial injury, say something from swelling, ischemia, or that movement of a bone into or against the spinal cord. So that secondary injury is what I was talking about when we are doing some of these immobilizations in the field, is we're attempting to make sure stuff doesn't shift around more. Now, from the process of swelling and whatnot, we don't have a lot of recourse over that. If that happens, that happens. But we can certainly restrict the motion, which is going to reduce the probability of swelling. And there can also be something called a spinal cord concussion, where we'll have a temporary disruption of normal spinal cord function distal to the site of the injury. So basically, if you wanted to think about it as some very minor swelling has occurred there, that swelling has put extra pressure on the cord, and that gives them a, maybe a temporary loss of use, some disruption in feeling, potentially even paralysis. That would be, that usually subsides within a few weeks to months. We can have complete and incomplete spinal cord injuries. So if we have a total disruption of the spinal cord, total loss of neurologic function distal to the injury site, and in most cases this is when we have something like a transection of the spinal cord. So a sharp piece of, say, vertebrae, sharp piece of bone has slid through and basically sliced the cord completely in half. Maybe we were shot directly through the spinal cord, or a knife blade, something along those lines that causes that complete severing of that cord. And when complete disruption occurs, swelling obviously will also occur. So that swelling is potentially going to migrate its way up the cord a little bit. So it may initially look worse than it actually is, because it may swell a couple inches up that spinal cord, causing another nerve set or two to be involved. The whole thing's going to be inflamed. So a lot of times it's a kind of a wait and see game as it starts to heal, to see how much is completely and totally involved, as opposed to just temporarily from the swelling. The full extent of an injury cannot be determined for at least 24 hours following the injury. And again, some of that is due to the swelling. We can have incomplete spinal cord injuries in which only a portion of the spinal cord is damaged. The next slide is going to give us a good picture of this, where we talk about a couple of different types of syndromes that go along with this, where we have central cord syndrome, anterior cord syndrome, and Brown-Séquard syndrome. So to look at each of these, we actually have a box coming up here. There we go, anterior, central, and Brown-Séquard. Anterior cord syndrome, most commonly seen from a bone fragment or introduction of pressure to the blood vessels of the anterior cord, anterior being the front, of course. So the loss of motor function and pain and temperature sensation at and below the level of the injury, but normal vibration and position senses typically remain. So it's pushing on the front parts of the spinal cord. So we could reasonably expect that this is probably an injury to the spinal body, or the vertebral body, so the big, heavy, thick part, and that's where this pressure is coming in. With central cord syndrome, this usually occurs with hyperextension of the cervical spine. So this hyperextension's started to pull, and it's really kind of pulled the center as opposed to pulling on the outside. It started to kind of stretch. We'll say that maybe the center doesn't have quite as much flexibility as the outside of the cord does. So when we get this kind of pull on it, it causes much more pressure on the center than it does the outside. So this is typically seen as weakness to the upper extremities, while the lower extremities typically will have their same normal strength. And it can cause some changes to their sensory functions. And then Brown-Séquard syndrome, this is a hemitransection. So this occurs on only one side. So you would lose motor function, vibration, and position sense on the affected side of the body, with loss of pain and temperature and sensation on the other side. Because remember, we have some crossing that goes on here. So it's really kind of a funky syndrome to see occur, where you have that loss of the motor function on one side and sensation really on the other side. Spinal shock, also known as neurologic shock or neurogenic shock. So this is a concussion-like injury to the spinal cord. In cases, causes neurologic deficit below the level of the injury. And when the spinal cord injury occurs, we'll lose that muscle tone, leading typically to paralysis below the level of the injury. That paralysis doesn't only show up in inability for us to use our arms and legs and sense, but also to change the size of our blood vessels. So for us to constantly have that constant tinkering that goes on with sizes of blood vessels and opening capillaries and closing capillaries, and open this sphincter and close that sphincter, and so on and so forth, in those cases we kind of lose that. So we can't have that ever-changing environment down there. It kind of becomes stagnant. And really that's what happens to the blood, is it stagnates because the vessels are too big. So if enough of the vasculature gets affected, they'll become hypotensive, which is referred to as neurologic or neurogenic hypotension. And neurogenic shock is a neurogenic hypotension resulting from spinal shock or from that injury specifically to the spine. The patient has relative hypovolemia. Now remember, when we say relative, it doesn't mean that they actually have low blood volume. They just have a lower blood volume than the size of their container. So we should typically have a 5 to 6 liter container, but over half of our body has decided to dilate all at the same time, so maybe we now have a 9 liter container, but still only have that 5 or 6 liters of blood to fill it. So things don't go anywhere. So here's a quick comparison of neurogenic versus hypovolemic shock. So the difference in the signs and symptoms of neurogenic shock patient is due to the loss of sympathetic stimulation, which is compensatory for hypovolemic. So the skin conditions for the neurogenic patient, they'll pale and cool above the level of the injury because the body recognizes, hey, here is a problem. We need to fix this. But below it, the body can't do anything about it. It's lost the ability to communicate lower and say, hey, we need to constrict. So that's why they will look flushed and warm below the level of the injury. Whereas in the hypovolemic patient, their entire body is pale and cool. The heart rate in the neurogenic shock patient remains within a normal range, and with the hypovolemic shock patient, they become tachycardic. So with relative hypovolemia, the patient becomes hypotensive. Ordinarily, the body responds through its compensatory mechanism, which are blocked because of the injury to the spine. So that sympathetic response leads to a release of epi and norepi into the bloodstream, gets lost. So our general assessment and management, we're going to begin our assessment by ensuring the scene is safe. Once we're on scene, we're assessing mechanism. With that high index of suspicion, or the patient that's telling me, hey, I can't move, that gives us that indication that we have a probable spinal injury. With motor vehicle collisions, we're going to look for things that would indicate a spinal injury, starring of the windshield, broken doors and windows, deformity of, say, the seats and whatnot, alterations in mental status, of course. Look for things such as cycle crashes, falls, blunt traumas to the core, penetrating trauma to the core, pedestrian accidents, hangings, divings, any unresponsive trauma patient, sports-related injuries to the back and the neck. So if they're unresponsive, they can't tell us yes or no. If they are responsive and they can very, very reliably and are extremely oriented, can reliably tell us what's going on with them, that helps us to make a better choice on whether or not they need it. But if they're unresponsive and can't tell us one way or another, our general assumption currently is that we will immobilize. So don't forget manual stabilization of the head and neck. This is one of your first hands-on things with your patient. Okay, this goes hand in hand with the way you open your airway. So if you have that unresponsive patient, you need to open an airway. It's a trauma patient. You're strongly suspicious that there could be spinal injury. Then this becomes not only spinal immobilization, but becomes modified jaw thrust. So we generally are going to grasp either side of the head with our gloved hands, place our fingers in a position that we can push the jawbone forward if necessary. We're going to instruct the patient to remain still and do not allow him or her to move. If we have a conscious patient that we're concerned with from the very get-go, from what we see on our scene side up as we pull up, we may want to instruct that patient, I need you to look straight ahead, do not move your head, do not look back at me, don't turn around. Giving them those sorts of things will those sorts of instructions will help them not move their head until you've had an opportunity to better evaluate whether or not they are appropriate for spinal mobilization. Okay, so and then we're going to maintain manual stabilization of the head and neck until the patient's spine is either fully immobilized or we've determined that spinal mobilization is not indicated. It is okay, provided that our protocols allow this and our medical director is comfortable with this. And perhaps we've even had additional education on the topic. That will allow us to do kind of some assessment-based spinal mobilization. Okay, if the patient's ambulatory, ask them to stand still during manual stabilization of the head and neck. Ensure adequacy of the airway, the breathing, and the circulation. In most cases, if they're standing, that's kind of an immediate assumption, yet understand that very quickly airway, breathing, circulation can become an issue with a patient who is up and around. As the injury progresses and as the swelling maybe gets worse and worse, we have more and more potential for that to become an issue. So if we got to manually open the airway, remember to use the modified jaw thrust, assessing things such as level of responsiveness. Don't forget that alterations may indicate head injury, but they may also indicate other things such as intoxication, other types of shock, hypoxia, hypoglycemia, and so on and so forth. So we have to know, we have to have a good understanding of neurology when it comes to medicine and neurologic injury when it comes to trauma. We have to have a good understanding on both sides of that to make appropriate decisions, because sometimes the mechanism of injury may not make sense. You're like, I don't see any damage here. There was no fall. Well, this doesn't make sense. But yet the call was for a car crash or for a fall or something like that. And 2 and 2 just don't add up. And then come to find out, oh, well, they're a diabetic, or, oh, well, they've been complaining of a headache for the last 3 days and have had slowly changing mental status and so on and so forth. Just as soon as I say that, I need to remind you, though, that sometimes patients are involved in a traumatic injury. Initially, they believe that they're fine, they're not injured, and decide, oh, no, I don't need to go to the doctor, I don't need to go to the hospital. They go home, and days later, they're found in a very bad state or near death or dead at home as a result of a slowly developing injury that they have. So we have to keep those things in mind. We can't always just assume that whatever happened 5 minutes before the call for help is what actually was the mechanism or the nature. Secondary. So perform, while maintaining manual stabilization of the head and neck, perform a rapid trauma exam. Now, note that says, while maintaining manual stabilization of the head and neck. This does not mean apply a C-collar and let go of their head. Their head has to be held neutral position until it is secured to a long spine board. We don't let go of the head until they're secured to a long spine board. Otherwise, somebody has to hold on to that patient's head until the time in which we turn them over, or we decide they no longer need immobilization. So, all right, and then as we do our secondary assessment, we're going to do that quick head to toe. Remember, before we would apply any C-collars, make sure and check the neck. Anything you need information from the neck, needs to be gathered prior to applying that C-collar, because the neck veins will be hidden, and it's very difficult to assess for any tracheal deviation with that little bit of a peak hole in the way there. So during your head-to-toe exam, assess the neurologic function, your CSMs, PMS, whatever you want to call it, of all the extremities. And this is going to be something that we repeat. So do it early to get your baseline, and then you're going to continue this probably 2 or 3 or 4 or 5 more times throughout the remainder of your time with the patient. So in male patients, we may also check for the persistent erection of the penis, which is referred to as a priapism, which is indicative of a of a spinal cord injury, because again, there's not directions being sent to the blood vessels of the penis to be a certain size. So therefore, there can be a large amount of blood flow that flows into the penis and causes the patient to then have a persistent erection. Now, when we talk about people who are on the phosphodiesterase inhibitors, also known as our erectile dysfunction drugs, those people, they say, an erection lasting longer than 4 hours. Of course, you should notify your doctor. Well, we don't have a 4-hour rule when it comes to trauma. Basically, it's inappropriate. It's at an inappropriate time to be having an erection. When you're suffering from a severe injury like that, there shouldn't be any stimulation there. So therefore, that 4-hour rule doesn't really apply here. It just becomes one of those that it's there and it stays. All right. So real quickly, to kind of scan through doing a brief neurologic assessment on our patients, we can assess flexion. If we have time to do this, this is perfect. This is great. This gives us lots of good information. This is more than you would do at an EMT level, yes, but you can do it as an EMT. There's certainly not a problem with that. It's just a matter of how much time it hands and the severity of your patient. So we're going to assess flexion. So he's really having them pull their arm up, flex their muscle, and then he's assessing it with his right hand in the patient's hand, assessing how much pull does he get there. And he would do this again on the other side as well. Then he moves his hand to the other side and is actually having them extend their arm out, push their arm out against his hand, being up against the back of their hand. So you also, while supporting the arm there, both for flexion and extension, can kind of feel the changes in the musculature with that left hand that's underneath the tricep. Assess finger abduction and adduction. So fan your fingers out, and he's actually kind of feeling to see what sort of strength they have to fan their fingers. Have them bring them together, add them together, bring them back close together. If you wanted to, you could certainly put fingers in between and kind of assess how much strength they have bringing them back together. But we're really more concerned, can they spread, can they bring them together. Assess the wrist and hand. So this is kind of similar to our push-pulls with our feet, where he's actually kind of has the bent wrist, says push up against my hand. He could also turn around and put his hand underneath and say pull down against my hand. I'm going to do this with the foot. So pull your toes up towards your nose, push down like you're pushing on the gas. So we had plantar flexion and dorsiflexion. We can assess the pain response or the sensation in the hand and in the foot. Assess the light touch. Can you feel this? This is something you, of course, don't want them to be able to see. So if they can see it, they're going to say yes. Okay, assess the flexion of the great toe on the same foot. So there's a variety of ways to assess how well they're doing, how much function they have, as well as their sensation. We can look at things such as their distal pulses, their capillary refills, those sorts of things. Color, for that matter, gives us a lot of information about the circulation. So management of our spinal injury patients, different for people who are standing versus seated versus lying. And we know this from our EMT. Immobilizing patients found seated inside vehicles depends on whether they're stable or unstable. We know nobody likes the vest-style device commonly called the KED. It is pain, and it takes a while to put on, but it's the right thing to do. It is the correct way to immobilize them until a time in which they change the standard of care. So, but putting a C-collar on, or I'm sorry, putting a KED or a vest-style device on takes time. If they are unstable, taking the time to put them into a vest-style device could potentially kill them. Sizing the cervical collar. There is a right and a wrong way to size cervical collars. You need to know how much or how large of a collar to use. You may use an adjustable collar, which requires you to measure, or you may have individual size collars. So with their head in a neutral position, draw an imaginary line across the top of the shoulders and the bottom of the chin, and use your fingers to measure the distance from the shoulder to the chin, or the angle of the jaw, really. So you set it up there, and this comes to about 3 finger widths. Certainly could bring his hand a little closer in there, and you'd see it a little better. So you measure that up to the mark on your collar, and that's going to depend on the brand you have. In this case, it's where the little black pin goes through, and that's about 3 finger widths from the bottom of the collar up to the sizing hole, or the sizing pin. And that's the one that tells you the correct size. Assemble the collar and then preform it. So if this came flat, give it a nice little molding into a round shape so it fits the patient's neck better. So applying a rigid cervical collar does not immobilize the head and neck, but it does assist it. Anybody who has been in a class before has put on a cervical collar, they've tried it out, and they know it does not hold your head perfectly still. I like to say the C-collar is nothing more than a reminder to not move your head. So size the collar, assemble the collar, get the collar ready. The chin must cover the central fastener in the chin piece. So if their chin is not going to sit up there on the chin rest, then the collar is going to be too tall. Bring the cervical collar into the patient. So bring the anterior portion of it up underneath the chin and into place. Wrap the back side around. Make sure the patient's chin's sitting up there on that central fastener in the chin piece. Bring the collar back around and fasten it securely. Doesn't need, not tight, but if it's too tight, it's going to cause them to have some hyperextension of their head. So fasten it on there, so basically is giving them the extra amounts of support. Should just clip the earlobes like you see here. So maintain that manual stabilization of the head and neck after you've applied the collar until they're completely secured to a long board. Reassessment of the motor function and sensation in all 4 extremities needs to occur at this point. So we assessed it prior to putting the collar on. We'll assess it again now that we put the collar on. Swelling can occur, and that can give extra pressure on that spinal cord. We need to be cognizant of that. We may need to adjust our collar as time goes. And we may also start to see changes in the patient's neurologic status simply for the fact that we have the continuing evolution of this injury. Document your changes on your patient care report. Not all injured patients require spinal immobilization. You may have a spinal immobilization protocol that will allow you to select some people to immobilize while others you may not. So you're just going to consider things such as mechanism, signs and symptoms, their age, and their level of responsiveness are the main key elements. So what MOIs are positive indicators for spinal immobilization? So we would look at things on page 893 where we talk about ejection of the patient, death of an occupant in the same vehicle, rollovers, high-speed collisions, extrication, time greater than 20 minutes, bumper displacement greater than 18 inches, intrusion into the passenger compartment greater than 20 inches, auto versus pedestrian at greater than 5 miles an hour, cycle collisions, depressed skull fractures, blasts or explosions, gunshot wounds to the neck or torso, falls from greater than 10 feet or 10 feet or less than 10 feet if the patient struck an object during the fall, blunt trauma above the level of the clavicles, or unresponsiveness due to trauma. So those would all be automatics. You're going to get this, even though you maybe aren't complaining of it right now. And those are kind of some automatic inclusion criteria. So we're going to assess our patient, make a determination based not only on the MOI, but the signs and symptoms that they show us. If the patient is unresponsive, boom, we know that's an automatic inclusion. If the patient is responsive and able to talk to us well and is oriented to what's going on, that's much more reliable. Ask them if their neck or their back hurts. If the pain is present, immobilize. Palpate the entire spine. Ask if there's any tenderness. If they have tenderness, immobilize. Assess for CSM deficits. If there is any deficit, immobilize. Do they have any distracting injury? This may make the patient less sensitive to the presence of other symptoms. So maybe they have another gruesome fracture or severe bleed or something along those lines that kind of has their attention away from their spine. If they have these present, in most cases, we're going to immobilize. So you have to have a protocol or a policy procedure to do this. There's a good example of this on 895 in your textbook. So if we look at 895, there's a little chart there that helps you kind of come to this conclusion. So basically starts with assess the mechanism. No mechanism, well, then we probably don't need to immobilize. Yes, there's definitely a strong mechanism, then we need to immobilize. If it's questionable, then we say, are they a kid? If they're less than age 5, they're probably not going to be able to give us reliable information to begin with, so we immobilize. If not, ask them, does it hurt? If yes, immobilize. If no, check for tenderness. If it's tender, yes, immobilize. If not, check CSM. Squeeze my fingers, push down on the gas pedal, etc., etc. If there's a deficit, immobilize. If not, we go down to, is it an unreliable patient, and does this include any distracting injury? If not, we don't immobilize. If yes, immobilize. So that's a pretty good little picture there, and I think a lot of systems are modeling their protocol off of this. But you have to go off of what your protocol says. Your protocol maybe still says everybody immobilize. This is something that the state is looking at very closely. So once you suspect spinal injury, manually stabilize the head and neck and maintain that until they're fully immobilized. So immobilizing supine and prone patients. We really aren't changing much here when we're talking about AEMT versus basic. Log rolling patients that are supine into position to place them on the long backboard, and then the patient's body is immobilized to the long backboard first, not the head. My recommendation is you will immobilize. There are 3 sections to the body. There's the chest and abdomen, or the torso, the legs, and the head. Immobilize the heaviest thing first, the second heaviest thing second, and the least heaviest thing last. So the heaviest part's the torso, the second heaviest thing is the legs, and the last heaviest thing is the head. Remember to move your patient along the long axis of the backboard. So we do not just shove on the middle of the patient's body to shove them over. Preferably, we're actually going to try to place them on the backboard so we have a little room to move them straight upward if necessary. So if we're going to have a hard time getting them placed perfectly the first time, moving them upwards and downwards along their long axis as opposed to trying to move them sideways is going to be much easier on them. All right, so with our 4 rescuer log roll on the backboard, immobilize and maintain inline stabilization. Apply your collar. Place the long spine board parallel to the patient. If at all possible, you can start to put some pads in the voids there. So you're probably able to assume that you're going to have a little bit of a void under the lower part of the back, so therefore they placed a towel. 3 EMTs kneel at the patient's side, opposite of the board. They leave space to roll the patient between them. The EMT at the head directs others to roll the patient as a unit onto his side and assesses the patient's posterior. So each person can kind of look over and check the back. The EMT at the waist reaches over, grasps the board, pulls it into position against the patient. or if you have another person that can push it into place, that works too. AEMT at the head instructs the rescuers to roll them backward. Secure the patient to the backboard with straps, so starting with the chest and the torso, moving down to the legs, and then to the head. Tie the wrists together loosely as necessary. This isn't always necessary. Sometimes the patient's alert and able to hold them themselves. Finally, using the head immobilizer, secure the patient's head to the backboard using the appropriate straps. Transfer them to the cot and secure. Okay, if the patient's found in a prone position, we're going to perform a manual stabilization of the head and neck. The head should gently be rotated into a neutral position as the body gets log rolled. We're not going to rotate their head neutrally while they're laying face down, because then we have their face in the dirt, the grass, the concrete, whatever. So we stabilize as we start to roll them, and I'll back this up. Sometimes the patient will also do kind of a crossed hand technique with you. If you pre-calculate this out, so when you flip your hands over, you actually have them crossed. So when he's rolled the right way, your hands actually go into a normal parallel position that you would be. In this case, they have not done that. If you take the moment and think about it, could make this whole job a lot easier, where you're not going to have to do any uncrossing or crossing of hands. So once they're in supine position, you immobilize them onto the longboard. Usually we'll suss their back while they're still laying prone. We get them ready to roll and put them right onto the backboard. And then, of course, padding the voids. Regardless if they're whatever position we find them, we pad the voids. Padding the voids provides comfort, and it helps give the extra support that we need. And this is an often forgotten about, left out step when we're doing spinal immobilization. All right. I think I'm going to end on seated here. We'll pick this up in part 2.